प्लीज सुन मेरी बात अनम्यूट इधर आओ ये अभी म्यूट आवाज नहीं ना जा रहा
A very good morning to all. I hope you all are fine and doing well in this time of global pandemic. I'm Tanya Chaudhary, DPT second year student from Banarsi Lal Chandiwala Institute of Speech Therapy. I would like to welcome you all in today's webinar. The concept of the webinar is to clear basics of X-rays as an investigating tool. When it comes to diagnosis of any condition, investigation plays an important role. So in order to increase the basic understanding of X-rays as an investigation tool, BCIT is conducting this webinar on X-rays. What physiotherapists need to know. This webinar will be having two sessions. Session 1 will be from 9 to 10 a.m. and the topic would be X-rays of major joints. Whereas session 2 will be from 10 to 10:40 a.m. The topic would be chest X-rays. The former one by a reputed radiologist and the other one by an amazing physiotherapist. Now, I would like to introduce and welcome our first speaker for the webinar, Dr. Devendra Kumar Singh, diplomat in medical radiodiagnosis, as well as a diplomat in National Board, an eminent consultant radiologist currently working in Fortis Hospital, Vasant Kunj. He has been working on all the modalities for 15 years and since 5 years in Mahajan Imaging. Thank you so for joining us. Now I request you to please continue the session.
So Good morning, everybody. I'm Dr. Devin, radiologist working in Fortis Hospital. Thank you for introduction, Dr. Sanya. I thanks the organizer for inviting me to having this talk, and I welcome all the people who have joined this webinar. So I'll just share the start sharing the screen, the Dr. Sanya. Uh, First, I want to know that is I'm audible to everybody. Somebody can say yes.
Yes, sir, you are on.
Yes, sir, you can audible.
Okay. So I'll just start sharing my screen in a second. 1 second. Can you see my screen?
Not yet, sir.
Not yet. Okay.
Yes.
Now
Yeah,
no,
it's visible now.
it's visible now.
Yeah.
Uh,
Yes, sir.
okay. Can you see the first slide of the presentation now?
Yes, sir.
Okay. So here now I will start. Is the slide is overlapped by the video by any chance? I mean, our image is on the right side. No.
No, sir. Nothing like that.
Okay. Okay. So good morning once again. So here the topic is what regarding the X-ray and what the physiotherapist needs to know. So in this session, we are going to learn few things like principle of basic radiography, like what are the principle, how the X-ray is formed, and how the image is formed. Just little brief, and the terminology, various terminology which is related with the radiography. Most of them must be you are aware of. And third thing, we will know the anatomy and normal appearance of the X-rays of different body parts, starting from the upper limb, then lower limb, and then the spine and the skull. And at the last, I will give the few example of the pathologies, like little bit of about fracture, tumors, and infection, how they appear. And one slide will be there for the radiation hazard because we must know because X-ray is a radiation, so it has a radiation hazard, and we should know that what we should not do. That we have to must know. Little bit about why the radiography is important, why we should know it. The radiography, the X-ray radiography is easily available to you. It will be in almost any of the clinic or hospital where the radiology facility is available. So it is very easily available modality. And most often it is the initial investigation which will ask down the line one day, maybe you are prescribing your prescription one day, or you are helping or working with the orthopedic colleague. So this will be the first investigation in orthopedic department or by you, maybe you will ask for. And that's why it is important to know the radiography, the anatomy and the basic principle. And of course the chest also dealing by my with other colleague. She will be the telling about the chest. You will use the radiography for follow-up. Once you have diagnosed something, whether fracture, tumor, or operated or treated, or you have put at the plate or something, then you want to follow it also, how the healing is, how it is going on. So that the follow-up will also require the radiography. Nobody will quickly ask for the CT scan or the MRI. And last, it's important to know the radiography and related stuff like terminology and projection, various projection for better communication with the orthopedics. suppose you want to say something, or orthopedically want to say you something, hey, do like this and do like this, or we should do like this and do. We should know the terminology exactly what he means. Or when you are prescribing any prescription to a radiology department, that okay, I want this particular X-ray, PAV or APV. These are a lot of meaning. Some of you are understanding what I'm telling.
Sir, please unmute yourself. Thank you.
Sorry. So the man who is behind this invention is the Wilhelm Conrad Röntgen. It was done, discovery was done in 1895, 8th November. So it's almost more than 100 years since the first X-ray of his wife was taken by Sir William Conrad Röntgen. Actually, there was a story that he was experimenting something with the Crookes tube. You must have seen in the science books this Crookes tube. He was experimenting this uh, rays, and it was covered with the some cardboard. And at the little distance in his laboratory was kept the plate of barium platinocyanide. So every time he charged this Crookes tube, there was some rays which is going and hitting the plate, and it glows. It glows in a dark room. From nothing else is happening. There is no other things is happening. And now this is how he came to understand this. Some unique rays is there in this room which is giving glow to the barium platinocyanide plate, and this is was the led to discovery of the X-rays. X means unknown. Nobody was knowing what this was. That's why he named it X-rays. On the right side of this slide, I have kept the modern tube. This was the old tube. This side is the, I will let you know later in the slide. This is the anode, and this is the cathode side, from where the electron was come and bombard to the anode, and the X-ray will come out. These are the modern version. This is the modern version. This disc-like material is the anode. It is called rotating anode. It always keeps rotating. And this is the filament from where the X-ray electron will come. Electron will go at a high speed and hit this target area. And from this target area, the X-ray will come outside the X-ray tube housing. I'll later just explain now. The X-ray tube is mounted in this part of the X-ray machine. Okay, and from here the X-ray will come out through the filter or through the collimator, and it will expose to the part where you have intended to put. Now, this is the cross-section area. This left side of the image is the cross-section diagrammatic image of the modern X-ray tube. The same thing which I was explaining you on the previous slide, that there is a cathode which is connected to the one part of the circuit, and when it is heated, the filament is heated like our bulb. Then the electron emits from this, and at high speed there is a potential difference between the cathode and the anode, and this accelerates the electron at very high speed, and then it bombards the target. And from this target is made up of tungsten. Why tungsten? Because tungsten is very heat resistant. It can sustain up to 3000 degree of more than 3000 degree of centigrade, and it can be, it's very malleable also. It can be stretched into a very thin wire. So once the electron will hit this target, through this filter and collimator, the X-ray beam will emerge, and it will expose to the part where you want to expose it. The same thing you can see here, the tube. Now it is exposing the forearm, and you can also see that this is the image which is generated of forearm, showing a fracture of the bone. This is the basic principle of the X-ray, and this is how the image is formed. This slide, I want to show how the X-ray machines are in any hospital or any clinic. This is our basic X-ray machine, and it has one detector stand. Okay, this looks like a digital radiography. This is the detector. This square box is the detector, and this is the tube housing. You know, where the tube is inside, and from here the exposure will go and hit the detector. In between, before the detector, you have to keep the patient standing. Say, for example, you are doing a chest X-ray, you have to keep the patient here. And this is the table with a bucket there inside where you can keep the cassette. The same kind of cassette will be available in your department of various sizes, 1417, 1014, and 1414. You can keep inside it. Then patient has to lie down on this couch, and the area of interest you have to keep in between the tube and the detector. We call cassette or detector, and this is how it is done. This is the C-arm. Many of you have seen in the OT, where you use for internal reduction of the fracture and to see the alignment, that is the reduction has been complete or okay or not. And this machine is a portable machine, of course. When you go to the ward, when patient cannot come to you, the ICU patient and the ward patient who are at the bed, you cannot move. This machine you can take there and do the radiograph. So these are the various hardware machine which are available in the market. And now I have seen it is one X-ray has came. Yesterday one person has came for demo. It was so small, it's just like a camera. I tell you, it is just hardly 1.5 kg of weight, and it gives just little bit exposure and 2 millisievert like exposure, and is very handy. No need of this much space requirement, but it is under trial. Nobody has using it too much, but it is under trial. So these are the hardware related discussion. Now we come to our main part. Now the most of the slides, next 20 slides maybe, I'm showing you the anatomy of the different parts, starting from upper limb, lower limb, spine, and skull. Why I want to repeat these slides again and again, because see, in this section, we have to be like in the same boat where regarding the radiologist or the orthopedic colleague and you. So many of us, you must be knowing the terminology. This is the anterior, posterior, the lateral side. So an anatomic position has to be clear to each of all of us, where the palm should be facing forward and thumb should be lateral. So no confusion for the radial side and the ulnar side. These are the various, again, basic planes. Sagittal plane, when you cut two half of the body, the coronal plane, anterior and posterior half you cut, and transverse section when superior and inferior half is the cut. This is the different positions of the patient for posterior anterior chest, lateral chest, the lateral decubitus, and the prone and supine position. These are the different terminology. I'm sure that many of you will be well aware of. And the schematic depiction of the action, flexion extension in the arm or at the elbow level, in the neck, dorsal and plantar flexion. When the foot goes up, it is dorsiflexion. When it goes down, it is the plantar flexion. In X-ray, there are projection terminologies are there. Projection terminology means you have to know that where the tube is and where the patient is and where the detector is. See, the first schematic, this diagram I have drawn, and most of these images, I must tell you that it is taken from a Clark book, Radiographic Positioning, and that was an excellent book. I recommend that sometime down the line you should go and see this book. Here is the tube. The tube is kept anteriorly. Patient is in between with a spine posterior, and then there will be a detector posteriorly. So this is the antero-posterior projection AP view, okay? And the middle one is the posterior-anterior view. When the spine is facing the tube and the chest is facing, this is the image. This is the image of the chest PA view projection where the chest is against the cassette. So this is called posterior-anterior projection. And the third image is the lateral projection. So in this all, there is one term will come, the centering of X-ray beam. You should know that where you want your center of the X-ray beam to be, because that will influence your quality of image. For large area, it may not be important, but when you are talking about want to take a finger radiograph, or you want to take a thumb radiograph, then you have to be very, very precise for your centering of X-ray beam. If you want your thumb and if you put into a space between first and second metacarpal, it might get a little blurred. These are similar terminologies for anterior oblique position and the posterior oblique positions. So in the anatomic part, I will first start with the hand. And in all these slides, I have kept the positioning of the part because maybe somewhere you are working later when maybe you have to sometimes check that whether this X-ray has come correctly or not, or you have a doubt that this image is not good, or how you will say that, okay, this image is good. So that's why the positioning you have to know so that you can manage your patient better or diagnose your patient better. So this is a posterior anterior view of the hand where centering is kept over the dorsum of the hand, center of the dorsum of the hand, mostly at the metacarpophalangeal joint area. You can see that there is one faint black cross plus sign is coming. So this is coming from the X-ray that collimator. It is for collimation of field of your view. Where you want to X-ray, that image will be collimated, means kind of a crop the area. And this is the centering. This black dot is coming for the center of the beam. After doing this, this kind of image will appear. This is a X-ray of an immature skeleton. Okay, maybe a young boy, who is less than maybe 15 years or 18 years. That's why you can see all the epiphysis. And this is the right side is the X-ray of a mature hand, where you can see there is no epiphysis. So first of all, in any X-ray, if you see, you have to decide whether this is a mature skeleton or immature skeleton. Anatomy of this area will shortly follow. So this slide I have kept for a little detailed anatomy of the part which is seen on the X-ray. So you can see here, this is the distal part of the radius and ulna, and this is the ulnar stelloid process. This is small area. Similarly, this broad area is called the radial stelloid process. And then comes the radiocarpal joint. This is the radiocarpal joint, the proximal row of the carpal bones, starting from lateral side or radial side, scaphoid, then lunate, trapezium, triquetral, and pisiform is overlapping over that. Okay? There is a two bone, one on the top of other. And then comes the intercarpal joint, the joint between the two carpal rows. This is the proximal carpal row, and this is the distal carpal row. So here is the trapezium. This I am outlining the margin, trapezium. Second is the stygioi. Third is the capitate, this big box-like bone. And fourth is the hamate. Within this triangular area, you can see another overlapping area, that is the hook of hamate. This is the hook of hamate. It is very interesting. It allows the passage of flexor digitorum profundus tendons, which is going to the little finger. And there are various attachment of muscle, like there could be flexor carpi ulnaris attachment, some more attachment which is going to the fifth finger. Next comes the carpometacarpal joint. The carpometacarpal joint between the metacarpal bone and the carpal bones. This is the first. The numbering is always from the first, and this is a universal numbering. You cannot change by yourself. You cannot say that side first and this side first. The thumb will be the first metacarpal bone, and then you can subsequently number on the other side. Then phalanges comes. The first thumb has only two phalanges, where the other fingers, they have a three phalanges, 1, 2, 3. So this is the base. This is called the base of the phalanx. This is called shaft of the phalanx, and this is called the head of the phalanx. Similarly, anatomy applies to all. Here also in metacarpal, this is the head, this is the shaft, and this is the base of the metacarpal bone. I'll show some abnormal slides later down the line. Next is the wrist. Wrist, similar way, it is kept, but little distal third of the ulnar radius is included in the view. And this is how the AP view appears, and this is how the lateral view appears. and these are the positionings. So already I have explained the carpal bones and the metacarpals and the radius and ulna. These above two slides, the left side, this one, is the patient with a cast. So that's why the images are not coming good. Many times in your orthopedic department or your clinic or your department in the ward, you will see this kind of images where it is cast is given, and the fracture line will be very difficult to visualize. The best information you can get from this X-ray is the alignment. Say, for example, if this is the fracture, you can say that after the reduction, the alignment is okay, though the images are not clear. So this is the X-ray with the cast, and this example is the fracture, little angulation with angulation of the distal radius. Similarly, the forearm, a little proximal X-ray with the center beam will be at the forearm. In forearm area, arm, forearm, thighs, and legs, this area you try to must include the proximal and distal joint if possible, and if there is a question of them. Say, for example, if there is a fracture of the both bone forearm, radius and ulna, suppose here there is a fracture, you should know that what is the condition of the proximal joint and the distal joint, and that is why we should try to include the proximal and distal joint in an area when the forearm is asked, especially if there is a high suspicion of fractures. This is a pathological example. In the right lower corner, you can see there is a displaced fracture with overriding fragments of the radius, and this is the Gallagher fracture. Both is the Gallagher fracture, where there is a fracture at the proximal 2/3 of the radius and distal 1/3, junction of proximal 2/3 and the distal 1/3 of the radius. Next come important is the elbow. So in elbow, the arm should be at the level of your shoulder only, and this is how they position it with the centering on the elbow. The anatomic area which is seen on this X-ray, I will explain in this image because there is too much labeling. You can just see by yourself. Meanwhile, I'll just explain here. This is the humerus, how it appears, and this is the radius, and this is the ulna. This part is called the lateral epicondyle. The medial epicondyle is little prominent and more projecting towards the medial side. A licensi is there, which is called the olecranon fossa, and where the olecranon process from the ulna go and fits into that fossa. The articular surface of humerus has two areas. One is the capitellum and other is the trochlea. The capitellum attaches to the radius. That is called a radiocapitellar joint or radiocapitellar alignment, we call it. So radiocapitellar alignment has a one unique thing, that whatever projection you will take, whether AP or oblique or lateral, the radius and capitellum will be at single line. They will not change the position, and this is important in children, especially where there is a development of the radial head is not full. So to know the radial head dislocation, that radiocapitellar alignment should be maintained. Otherwise, there could be a question of dislocation, though may not be there fracture. In the center of image, I have just shown the fracture of the radial neck. This is the head, and this is the articular surface, and here is the neck. So this is the fracture of the radial neck. Similarly, there may be you come across fracture of the supracondylar region, fracture of this part, fracture of epicondyle. There could be fracture of ulna, or there could be dislocation, which I'll just show you. These are the various pathology of elbow, because this is one of the most common joint which is involved in injury. So first image, if you want to be a little bit more specific in your observation, then you will see that there is a little bit of fat will be there here to the humerus. You can see here there is a thin lucent line is there if you can pay attention, and this line you can go and see in your radiology department. This will be always visible, this dark little faint line. This is the soft tissue, this whiteness. This is the air density, dark, very dark. In between this darkness and soft tissue, there is a thin line that is the fat. And if it's fat, this is totally displaced anteriorly. Okay, then it is maybe a indication of intra-articular injury. Something has happened to the joint, which is causing effusion of the joint. So this visualization of anterior fat pad, this arrow, and there is a posterior fat pad also, which will be displaced posteriorly. This hints the intra-articular injury has happened, whether effusion or effusion due to fracture or effusion due to any reason. Similarly, the other examples you can see the dislocation, posterior dislocation of the elbow joint. This X-ray shows the fracture of the radial head. You can see a vertical line which is passing through the radial articular surface. And here is the avulsion injuries from the lateral epicondyle from this chip area. And this is the fracture of olecranon prosa. This is a avulsion fracture of triceps. Triceps is attached at this point. And when there is a sudden contraction, there might be a avulsion fracture of the olecranon process. This fragment is a little bit bigger, but usually there will be a small fracture will happen from this step. Next anatomic location is the shoulder. You can see the shoulder for AP projection. We center here, and this is how our image comes. So this is the AP view of the shoulder, and this is the superior inferior image of the shoulder, where it's kind of axial view. We can say it is an axial view. And in this anatomy, this is the AC joint. This is the glenohumeral joint. This is the glenoid cavity, and this is the articular surface of the humeral head. This small area is the footprint. Maybe it is seen on the next slide. I'll just go to the next slide. Sorry. So here I will explain. This is called clavicle. This bone is clavicle. And here is the AC joint. This is the acromion process. This is the spine of the scapula, the lateral part of the scapula. And this part is the footprint where the supraspinatus tendon comes. The supraspinatus tendon comes and goes and attaches here. This is the greater tuberosity. This is the lesser tuberosity. In between these two, we call it is a bicipital groove, where the biceps tendons comes down and attaches to the radial tuberosity. And here one overlapping bone you can see, this one, this part is the coracoid process. It is an anterior structure overlapping the glenoid. So below the coracoid process, from this big area, anteriorly, the subscapularis tendon comes and attaches at the lesser tuberosity. And rest of the other tendons of rotator cuff, because a lot of patients will come to you with a frozen shoulder. See on the top, there is one image I have put, how a degenerative shoulder comes. So frozen shoulder will not be seen like this. Frozen shoulder will have a soft tissue abnormality, capsular thickening, capsular stretch will not be there. But this is a degenerative joint where the joint space will be reduced and cartilage is thinned out. That's why there is a arthritic changes and degenerative changes. These all patients will come with the complaint of pain and restricted movement of the shoulder, and then your job will come in for physiotherapy and all, and exercise. That is why we should able to know this all anatomic location. On this axial view, it's important to see the coracoacromial arch. See, this is the clavicle is coming, and clavicular and acromial arrangement, you need to see alignment. So whether it is maintained or not, or it is displaced anteriorly or laterally. And in this, you can see the coracoid process very clearly here. This is the coracoid process, which is seen on AP view like this, because this is an anterior structure. So you know that this is anterior, this is posterior. This is the same leveling of the shoulder I have already explained. This slide is pathological examples of some common shoulder conditions. This this slide, if you see, normal you have already seen. This humeral head, the humeral head was in this location, glenoid location. Okay, okay, now this humeral head is moved just below the coracoid process. So that's why this is an anterior dislocation of the shoulder. And this is one of the commonest dislocation of the shoulder which happens in the body, anterior dislocation of the shoulder. The shoulder is the commonest and most commonest joint to dislocate. So due to dislocation, sometimes the glenoid hits on the posterior superior surface of the humeral head, and it can cause an impaction fracture on the posterior superior aspect of the humerus. And this how the indentation will appear. Similar images you can see here also almost. This is again the similar anatomic depiction of what I have told. So shoulder dislocation is very important. Apart from shoulder dislocation, there you can see acromioclavicular dislocation. So this is space. This here is a one joint. It's called coracoclavicular joint. There are two components, coracoid and conoid part. If this space is too much separated, and this AC joint is space is more than 5 mm, then we have, and there is a history of injury, then you have to suspect there could be a AC joint subluxation. There are various degree of AC joint subluxation in which the joint space will increase first, and gradually then this space will increase because the ligament will be torn here in severe cases, and the space will increase. Similarly, there is a subacromial space also. This space is a subacromial space. From here, supraspinatus tendon comes and attaches this. Suppose if there is a soft tissue spur or calcification arising from inferior aspect of the acromion, it can restrict the movement of the supraspinatus tendon and cause a pain and impingement. And that's why the space should be enough and we should pay attention. In severe arthritic patient, this space can go reducing and reducing. And finally, there could be a tear of supraspinatus tendon. These are all for MR diagnosis and ultrasound diagnosis. They are not, cannot be seen on X-ray. You can only speculate or you can guess, oh, this space is very much reduced. So is there any problem of impingement could be there? Apart from bone, sometimes you need to see the soft tissue calcification also in the any joint you are studying, whether it is a hip joint or whether it is a shoulder joint or whether it is a knee joint. So here, because we're discussing shoulder, you can see there is a calcification which is directly coming over the supraspinatus tendon insertion. So this could be a supraspinatus calcific tendinosis. There can be calcium deposition in the tendon. And the second possibility, it can be a calcium within the subacromion subdeltoid bursa. Over the top of the supraspinatus tendon, from here onwards down till this line, there will be a subacromion subdeltoid bursa. Here is the part of subacromion, and from here onwards that bursa will come. It is not seen here. I'm just telling because these are the anatomical location. When that bursa fills with fluid and later calcifies, the calcification can be seen here, and they can cause impingement and pain. A tiny faint calcification you can see here also within the tendon. Next is the foot. Foot centering you can see for oblique. This is how you do the centering for the oblique foot. And I'll shortly tell you the anatomy. Just I'll show the position first. This is another image, leveled image of the foot, where you can see the metatarsal bone. You can see the phalanges as same as in the hand. There will be proximal, middle, and distal phalanx. This is the metatarsophalangeal joint. This first joint is often the site for the gout and arthritis. Many patients with uric acid elevation there can have a swelling and pain in this area. Then you do the X-ray to see the soft tissue calcification or sometimes tophi and erosion of bones in this area. And this is the tarso-metatarsal joint from first to the fifth. This is the base of the fifth metatarsal bone, where sometimes you can see the fracture. The down images, the lower images show the same. On the left side, you can see there is a vertical lucency or vertical defect is there between the base of fifth metatarsal bone and this small bony fragment. This is the epiphysis. This is the epiphysis. So second is the transverse. So this is the fracture. So this is the difference between the normal variant, which will be seen in immature skeleton, and this is the fracture on the right side. This is the AP view of the foot, where mostly you are evaluating the middle foot, midfoot, and the forefoot. In the oblique view also, you are mainly centering on the midfoot and the forefoot. For hind foot, you can see more in the lateral view of the ankle joint. There you can have a calcaneum and this talus. Here also you can see the angle between the calcaneum. This is the talus bone. This is the navicular bone as a cup-like attachment just anterior to the talus. Here you can see the distal part of the medial malleolus of the tibia and the lateral malleolus. And again, the intertarsal joints and all you can see very well. Lateral view. Lateral view is a very important view where you can assess the arch of the foot, the longitudinal arch, plantar arch, which has this kind of concavity. You can assess all the metatarsal bone arrangement, the arrangement of the cuboid, and the calcaneum. If they are flattened, so here you can diagnose the flat foot. So in flat foot condition, this calcaneum will be way much down. It will come here, and the cuboid also will come here. This loss of longitudinal arch also happen in many other conditions apart from congenital. You must be knowing it can happen in the neuropathic joints. It can happen in the fracture. It can happen in the soft tissue contracture also. And the anatomy will just revise. This is the distal part of the tibia. Here is the fibula is coming overlapping. So the lower part which is going is the fibula, and the upper part is the medial malleolus. Posterior is the calcaneum. This is the talus, the neck of the talus, and this articular surface of the talus, head of the talus. This is the navicular bone and the intercarpal. So next. Okay. So I don't know from where this marking sense came. Anybody can see this marking on the presentation?
Yes, sir.
Yes, sir. Yes,
A big mistake. But I don't know how to.
There is an option of more, maybe 3 dots or more. You can stop this.
But I don't know. It is happening by its own probably. One second. Okay. Okay, just only mouse I'll take. Thanks. Hopefully it will not happen from now onwards. Clear all drawings. Okay. Thanks. Sorry. So this is another example of pathology of foot, where you can see there is a hallux valgus of the foot. There is a lateral deviation or at the metatarsophalangeal joint, first metatarsophalangeal joint, where the phalanx is deviated towards the lateral side. So this is the hallux valgus kind of deviation. And this is the fracture of the middle phalanx, where the, proximal phalanx, where you can see there is a displacement. Now comes the ankle joint. For ankle joint, AP and lateral view, we keep the centering on the, exactly on the ankle joint. And this is the image which comes on AP view. You can see the nice tibio-talar joint and joint between the fibula and the talus. So this is almost a mortise kind of view where you can see throughout the joint space between the talus and the tibia and the fibula. So anatomically, there is nothing new. This is the tibia, fibula, and the talus. Here again, sometimes in fracture, you can see the fibular fracture is there at this location, and this patient is in the cast. And as I told you, in the arm and wrist also, there will be difficulty in visualizing the fracture, where the fracture is. This is the lateral view. This is how the lateral view of the X-ray will appear with the all landmark. The lower landmark here in the overlapping area, you should must know that it will be a lateral malleolus, because you can see on the AP view, the lateral malleolus is coming down way below the medial malleolus. That's why on lateral view, the conical bony projection overlapping the joint, below the joint line especially, will be the lateral malleolus, because sometimes there could be a confusion for the fracture on the lateral view. And these are the important subtalar joint. This is the sinus tarsi. This is the posterior subtalar joint, talocalcaneal joint. This is also known as subtalar joint. This is the posterior tubercle of the talus. Sometimes this posterior tubercle will be very much elongated and broad, and we call it as a stira process. And they may or may not be symptomatic. And if there is a fracture of that process, then can be a symptomatic complaint of posterior pain, hindfoot pain. Next important bone is the calcaneum, because this is the first bone which might can involve in fracture when the patient is falling from the height. I'm sorry. When the patient is falling from the height. So in lower image, you can see there is a fracture which is going through the posterior part of the calcaneum and up to the subarticular joint. In this example of a soft tissue calcification, very, very common, we call it as a plantar. We call it plantar fasciitis, where the calcification will be there in the plantar fascia, and there will be a lot of heel pain will be there. Patient cannot move whenever he will land his foot. There will be a pain because of this spur-like projection in the lateral view. Second, this is the fracture of the calcaneum. Again, we are showing the same thing. Okay. The next is like forearm, you do the imaging. This is the tibia and fibula. And as I told there also that we should include the joint above and below. Try to include the joint above and below in the leg and forearm x-rays. So here the knee joint and the ankle joint you can see in this view. And this one is the example of both bone fracture, where the proximal 1/3 of the fibula is fractured, and there is a spiral fracture or oblique fracture of the distal third of the tibia. The next important anatomy is the knee. It's very, very, very commonest symptomatic area, especially in the older age group, and of course now in the younger age group also, because of the various internal derangement of the knees and injury to the supporting ligament. So this is the anterior projection and AP view projection, okay, and this is the lateral projection. So let's first look at the lateral projection anatomy. So from the top, when you come down, this is the shaft of the femur, and this bulbous area which is overlapping. There are two areas. One is the lateral malleolus, and another is the medial malleolus. Condyle, epicondyle, medial epicondyle, and lateral condyle of the femurs. You can see the medial condyle is very much big and broader. That's why it comes below the lateral condyle. And this is the patella, superior pole, inferior pole. And in most of the X-ray, you will mark this quadriceps tendon very well, especially in the thin patient. It is very well visible. So we should always try to identify, because this is the important stabilizer of the extensor mechanism, is important factor of the extensor mechanism. And if this fat, which is between the femur and this quadriceps tendon, is not present or is too much disturbed, then this is the site of the pain, then you can think of this quadriceps problem. And patellar tendon also you can see very well, though the soft tissue are not well visualized, but these are the area where, due to the natural contrast, this soft tissue structure can be visible. Same thing with the tendoachilles tendon. If you see the lateral x-ray of the ankle, there you can see the similar structure above the calcaneum, that is called tendon achilles, very strong structure. Let me show you if I can find. Yeah, you can see this. You can see this area. This area is the tendoachilles tendon, which form from the soleus and the two gastrocnemius muscle. And because there is a fat anterior to the tendoachilles tendon, that's why we can see it very well outlined. And this is called Krager fat pad. This fat known is the Krager fat. You can see here also. See, this is going like this. So similarly, in the knee also, you can see the quadriceps tendon most of the time very well. And if this is not seen, not in a very heavy and fatty patient, but in a normal population, you must see this both tendon, quadriceps tendon and the patellar tendon. Okay, and this is the inferior pole of the patella, and this is tibia. And this is the Hoffa's fat pad. This area is the Hoffa's fat. These all are visible well and very well in the MR. You will learn later for sure. This inferior part is just, I'm showing for example, I was talking about, see, this area should be loosened, but in this example, there is a fracture of patella, transverse fracture of the patella. Above the patella, you can see there is a oval soft tissue has appeared, which is obliterating this dark space. Okay, this fat-like space, it is obliterating. So this is the indication for suprapatellar effusion or effusion in the suprapatellar pouch of the knee joint. Suprapatellar recess, we call it also. And this is the oblique fracture of the distal part of the femur, almost in just above the level of the condyles. Skyline view is very important to see the patellar instability in a young patient who has a recurrent dislocation of patella, and in the older patient where you want to know whether there is a osteoarthritis or not. You can see there is a reduced joint space, subarticular sclerosis. This is a little bit sclerosed. See, this is here nice and smooth, good space maintained, but here you can see it is irregular and there are some osteophytes also appear. See this, osteophytes. So this is the patellofemoral osteoarthritis, and also involving the femur also. And this is how we take it. There could be a variation of the patella, various degree could be there, but this is how we have to angulate and make the patella kind of a profile view, in the profile view, so that it should be separated from the femur, condyles of the femur. Now the next large complex three-dimensional area comes is the pelvis. It's a very big area because it's in AP projection. See, this is the anteroposterior projection of the pelvis, and this is the lateral projection of the pelvis. So this in anteroposterior area of projection, there is a lot of organ comes. In the center, you will have a pelvic organs of the male and female. In the posterior to this iliac bone will be the gluteal region, and anteriorly there will be a whole abdomen where the bowel loops are there. Apart from this, within this area, you have to take a good image of your bone, which showing the lower part of the fourth and fifth lumbar vertebrae, and this is the sacrum, this is the ala. This vertical faint line is the SI joint, okay, and this is the iliac crest. This is the iliac crest. This is the iliac bone. This is the superior inferior iliac spine, inferior iliac spine, and this is the acetabulum. This is the iliopectineal line. This line is called iliopectineal line. This is the symphysis pubis. This is the superior pubic ramus. This is inferior pubic ramus. This is the obturator foramen from where obturator nerve and artery goes. And this is the greater trochanter. This is the lesser trochanter, femoral head, and femoral neck. And on lateral view, it is still more,
उंगलियां ऐसे कर लिया कर दिखाओ ना उंगलियां
even if it's more confusing. The lateral view, even if it is more confusing, because the ileum you won't be able to see. Because look that how this is the obturator foramen is seen overlapping the femur. In lateral view, we are trying to see the sacrum, of course, and coccyx. This gives a better view, and iliac bones are mostly seen on the AP view only. This is even more same detailed anatomic leveling. I have discussed all, but this area is the right hip joint. This is the AP view, and this is the lateral view. Okay, and with internal and external rotation you can see, but this is the main view, AP view, where you can see the same anatomic area which you see on the pelvis, but this time your centering will be on the right hip joint. That's why you have a very clear outline view of that area. Here your centering is on the pelvis, so the details will not be that great, but in the femur, in the hip joint, you will focus mostly on this area, and that's why you will get this kind of very detailed image. Now in hip joint, you have an articular surface, okay? And this is the acetabular surface. And this is the head neck offset, and this is the neck area. So we call it as a subcapital. This is called a subcapital. This is called a subtrochanteric because this is between the true trochanter. This is intertrochanteric. This is where one of the most common fracture, intertrochanteric fracture happens. And this is the area where neck fracture of the femur happens in the older age group or even in the younger age group. And these other areas are important to see the alignment, whether it is laterally and medially displaced. And you can see this, sometimes the hip joint projected inside the pelvis also. If this articular surface goes beyond this iliopectineal line, or this medial acetabular line, this medial wall of the acetabulum, then it is called protrusio acetabuli. Means the femoral head is protruded into the acetabulum, into the pelvis. This is the same diagrammatic depiction of the AP view. These slides I keep just to tell you that many times in the pelvis you will do the imaging of a pregnant child or reproducing age girl or the young children. So in that case, you have to protect their gonads and you have to put the shield. So this is a shield. Sometimes oval shield will come for female, and this is sometimes come for male. But the female gonads or any kind of lead apron, if you are not interested in this pelvis area and you are doing a spine and all, you have to cover this pelvic area. And if you are interested in this area, then at least you have to cover this part of the pelvis. If you are interested in hip joint, then you have to cover this part of the pelvis so that their gonads should be protected. I will show you a slide of radiation hazard in the last, and it is important to discuss here. These are one of the don'ts. Don't do those things in the X-ray because there is a potential radiation hazards are there. Therefore, in a pregnant patient, in a young patient, in a child patient, or in a girl of a reproducing age group, or for that matter, even in elder also, you should not expose this area unnecessarily. If you can avoid the exposure or if you can protect that area through putting the shield, that will be very good. So this image I have taken to just show you. Many times you will see the hardware also, which will come for follow-up. So you can see here, this is the total hip replacement prosthesis, where you can see the prosthesis is noted on the both side with little bit of extended limb into the proximal femur. Sometimes this will not be, strength will not be well enough to have a small, this stem. So this stem is going inside the bone to give the stability of this THR. Next is the SI joint. The SI joint is seen in the pelvic view, pelvis joint. You can see even on the lumbar spine AP also you can see. I'll show you the image later. But SI joint is one of the area which is the cause of the low backache in the most of the young patient or the older patients. So this is how the SI joint will look. You can see SI joint in the AP projection also, and also you can see on the PA projection. The PA projection will give you this kind of different view, and AP projection also will give you this view. The PA view is more, you can see more clear, where the joint space is seen very well. So many patients will have ankylosing spondylitis. In those patients, we need to see the SI joint because that is the most common area, the disease where it starts, the ankylosing spondylitis. Now we move to a large anatomic and long anatomic area, that is vertebral column. You know that it starts from the C1 down to the coccyx. So coccyx area we have already discussed, a little bit we have discussed. You have seen the at least images on the lateral view of the pelvis. Now we will see the vertebral column. So this image is very, very important because what happens in the X-ray department or whenever you are examining also, you need a surface landmark. You surface landmark that where the patient is telling the pain and where you will refer to the other people, what you will say that which level the pain is and which level the X-ray you need to take. So you should know the normal surface landmark. I'm sure that many of you have seen already learned in the anatomy class. This is the sternal notch, the sternal angle, which correspond to the 4-5. Roughly, they are not very strict, but more or less they falls into the same angle. This sternal angle is very important. The sternal notch is very important. And same way for the lumbar puncture and all, you can have this third lumbar vertebra and third and fourth lumbar vertebra. And Jiffy sternal joint, which has a front, the umbilicus. These all landmark we should know because we can appropriately direct or communicate with the radiographer or the orthopedic colleague. And you know already the 7 cervical vertebra is there, 12 thoracic, 5 lumbar, 5 sacral, and 5 coccygeal segments are there. Sacrococcygeal segments are very varied. So now let's start with the lateral view and AP view of the C spine, where you can see the position of the patient. For the lateral view, she will be close to the cassette, and this is the view in flexion and extension. This is the flexion where she flexes the head down and to see the instability basically at the C1, C2 joint, and for that matter, any of the joint up to the C7. If there is a history of trauma, if there is a history of degenerative joint disease, disc disease in the older age group, there can be a listhesis. We'll call it enterolisthesis, we call it retrolisthesis. To see those alignments, see this line here, I'll show in this. See, this is the posterior longitudinal line. This line should be, an alignment should be perfect. It should not be anterior and posterior. And when the patient has instability due to any reason, whether it is congenital or due to trauma or due to degenerative disc disease, advanced degenerative disc disease, this alignment will be disturbed. Either this vertebral, this posterior margin will go anterior and this will come posterior, or it can happen in the C1, C2 joint. C1, C2 joint is a very special location because you can see at this joint there is a lot of bone from anterior to posterior. This much thick bone is there and you have to focus the center of this area, especially on the AP view. That is why people discovered that if you open the mouth, open mouth view we call it, if you open the mouth, then the air will work as a contrast, and if your beam will pass through like this, then you will get the image of open mouth view of C1, C2 vertebra. So C1, C2 vertebra has to be imaged especially separate, and the rest of the spine information you can give the information in a different way. Like this is the information for the rest of the spine, and this is the information for the C1, C2 joint. Now, anatomically, we know that C1 has a condyles, and this C2 has a dense process, and there is a joint, C1, C2 joint, atlantoaxial joint is there. rotatory and anteroposterior movements are there. And this is usually involved in rheumatoid and tuberculous disease. So that is why you need to have a follow-up also. Then there are congenital disease also, like atlantoaxial subluxation in the children. Then due to Arnold-Chiari malformation, posterior cranial fossa malformation, and C1, C2 dysplasias are there. They will cause instability of this joint, and that's why many follow-up patient will come with a processes between the occipital bone and the C2 and C3. In those situations, you have to look for this atlantoaxial distance. Where I am moving the cursor, this is the atlantoaxial distance. Axis means this dense axis, this one. This is AP projection. This I am talking in the lateral projection, where this is the atlas and this is the axis. There will be distance of 3 to 4 mm in the normal population. When this distance increases to, say for example, more than 5 mm, then you have to suspect subluxation. Atlantoaxial distance will be increased more than 5 mm. Then there is a suspicion of subluxation. You can inform your the radiographer that okay, this is space increase. Can you do a flexion extension more, where it will be more easily seen. If it is a hidden or a occult kind of subluxation, it will be more easily seen on the flexion extension view. And this lateral subluxation will be seen on this view, where there is a fracture and they can move laterally. This we can follow on the follow-up X-rays. Next is the thoracic spine. Thoracic spine is a long segment, 1 to 12. So we see here the same listhesis, vertebral body collapse. If the vertebral height is reduced or it has moved anterior and posterior, the listhesis in the history of trauma or fall, we can assess those areas. And similarly for metastasis, for fractures, those we can see. Now we are moving to the lumbar spine. Shortly, I will just share the anatomy of the lumbar spine, because the anatomy is almost same in the entire spine, and lumbar spine has a broad and big vertebra, so the visualization of all those parts is more easier. So here you have a lateral view, and this is the AP view of lumbar spine. The parts which you are seeing here is the body. This is called the body of the lumbar spine or vertebral bodies. Here is the in-plate, superior in-plate. This is the disc space. This is the pedicle. This one, this is the neural foramina. This is the neural foramina, and this is the superior articular process. This is the inferior articular process. And this part between the superior articular process and the inferior articular process of the above vertebra is form the facet joint. And you can see the lateral view, the ribs are coming. This must be the 12th rib, the last rib containing, because if you count from below, this is the 5th rib, 5th, 4th, 3, 2, 1, and this is the 12th vertebra from where the 12th rib is coming out. This is how we count the number of vertebra on the X-ray also. On the AP, the spine can be seen very clearly, spinous process, not spine. Here you can see Fentley here. You can see Fentley at each and every level. This spinous process is the spinous process of L3 vertebra. Similarly, there is spinous process of each and every vertebra. So this is the pedicle. This one, which is seen as a round lucency, is the pedicle. This pedicle you will come across to see in metastasis patient. They are commonly involved. So the impression which you are seeing here, it can be absent in the, say, sclerotic metastasis from lung or the breast. This can disappear. So this is the SI joint, which I'm talking about in the previous slide, that you can see commonly in the AP view of the lumbar spine, the SI joint, you will have some idea of SI joint. This is again the anatomic leveling of the entire spine. these are the area of paying attention. See, the vertebra is seen very well. Disc space is seen very well. There is no problem. But here is some overlapping structure, which already I have explained that this is called the superior articular process. This is the inferior articular process. So between this superior articular process and inferior, there will be facet joint. These are the one of the commonest area of back pain, where the patient may not have much disc disease, but the pain is lying on the pain generating area is the facet joint. Therefore, you can see that many times you give injection, your senior or the orthopedic colleague give injection in the facet joint because that is the pain generating area. Of course, for all this detail, you need the MRI where you can confirm your findings. Yes, the facet joint is the pain generating area. And disc, degenerative disc disease of lumbar spine, that is also called lumbar spondylosis. There are 2-3 terms which you will have must have read, or commonly it will come to your book. Is the spondylosis means degeneration. One is called spondylolisthesis, means displacement, anterior and posterior displacement of the one vertebra over other. That is called listhesis. And one is called lysis, spondylolysis. Spondylolysis means breakage of the pars interarticularis, this part, just above the articular, superior articular surface, there will be a pars interarticularis. And if that breaks also, there will be a listhesis. So break of that area is called spondylolysis. So always remember this three term when you are talking about spine, especially lumbar spine. Spondylolysis, that is nothing but degeneration. Spondylolisthesis, when there is displacement, anterior and posterior displacement. And the third is spondylolysis. Chest I will skip because mom is done. So I am almost near to that normal revision of the anatomic areas. And this is the last anatomic area of the bone related, the skull. The skull again is a very complex three-dimensional structure, but X-ray will help you to just have a guide of what is happening overall in the skull. And if you can pinpoint a particular area of pain due to injury, infection or tumor, then you can image that area. I'll just revise the basic anatomic location in this skull. Let's start from the pituitary fossa. This is the pituitary fossa. Okay, this is the posterior clinoid process or dorsum sella we call it. And this is the clivus. Little bit you can see the clivus. This is the base of the anterior anterior skull base. Okay, and here will the middle skull base. Okay, and this is the sphenoid sinus, which is seen on the lateral view, sphenoid sinus. This is the frontal bone. From here till this region is the frontal bone. This is the coronal suture. This marking is the coronal suture. Sometimes in older age group, they fuse earlier. I hope this is a probably X-ray of an older patient. That's why may not be clearly seen the serrated and interdigitated margin of the coronal suture. We are not seeing very well, but this is the coronal suture. And if you come here, this is the lambdoid suture. Lambdoid suture. And below is the occipit bone. So this area is the occipital bone, this entire area. From here to here is the parietal bone. And here will be the junction between the, or suture between the parietal bone and the temporal bone, this region. So there are, you know, that 4 bones are there in the skull. And anatomically, we identify them like this, because in many times the child will come, then this bone will not be there because they are not fused. So you will come to know them in easily that these are the area of frontal bone and this parietal bone and temporal bone. This is the area of orbit. This is the superior orbital margin. You can faintly see the boundary of the frontal sinus also. This is the frontal sinus area. Okay. And this is the area of nasal septum. This is the medial wall of the orbit. These are the ethmoid sinus. So in skull X-ray, there will be many times it will be difficult to find a fracture. It is very, very difficult unless it is clearly seen, especially in this area. And clinically also, you know that this is the area of the So next I am slide. A little brief about how to read the X-ray. So that's why I've spent so much time on showing you the normal appearance of all the sides of the anatomic area of the common joints and bone. Because if you don't know how the normal looks, you will not able to identify the abnormal. And in normal, not only of the adult age group, you have to identify the uh, child age group also and older age group also. Therefore, please go through anatomy and all the landmarks. Then you will able to understand and able to read the X-rays. Next comes the for all the segments, whether it is radiographer or the the physiotherapy students and the consultants or the orthopedic people. You have to take the history. So where is the problem and what is the problem? That's why normal appearance and history. Once you are familiar with all these normal appearance and take history, then you can come to that particular area, whatever the area you're studying, whether it is a joint or long bone, you need to see the alignment, whether your bone alignment is correct or not, like elbow dislocation, shoulder dislocation, ulnar fracture, radius fractures, the alignment is gone. So alignment is maintained or not. Next comes the density. You have to remember the normal signature, normal brightness or darkness of that bone, cortex and medulla we call it. Cortex and medulla, we need to know it. Whether density is reduced in osteopenia, and density will be more in the metastatic lesion or fluorosis or in the renal patients, in the long standing chronic kidney failure patient, the density of the bone will be increased in the vertebra, that is called Rugger-Jersey spine. We will see on the images. Then the shape and size. Is the shape and size of this area of bone is changed or it is same? Shape means whether it is expanded or it is break, it is not there, or if the size, it is one-sided, it is increased. So these are the things you need to tell about the bone. And you must have to see in the adjacent joints. Like if you are reading the forearm or if you are reading the leg, then you must see the one joint above and one joint below, that how they are. And these are the like broad points which I want you to exercise before reading the X-ray. So it will be easy to for you to not to miss the, because many times there will be normal variants also. I have not included here, but many times you will have a normal variation of the X-ray appearance, small variation. There will not be that too much, but there will be some normal variation, some calcifications here and there will come. Coming to the end of our presentation, now I am showing some pathological examples of the classic pathological examples. See, the disease broadly, we know that it is divided into whether it is a traumatic injury or traumatic etiology for the bone and joints, or congenital, means by birth it is, or infection it is, or tumor it is. These are the 3-4 categories, 2 or 3-4 categories which are always be seen. So first I will show you the fracture, neck of femur. You can see this place, this is just below the head. So this we can call it a subcapital fracture. Previously we used to call it a subcapital fracture because it is just below the head of the femur. And the risk of this kind of fracture is the avascular necrosis of the femoral head, because the more close to the femoral head the fracture will be, more easily there could be a vascular necrosis. And that early diagnosis again will be done on the MR. Yeah, on X-ray it will appear very, very late. Once there will be full sclerosis and collapse of the articular surface of this bone, then you will come to know the avascular necrosis of the femoral neck. This I want to show is a very, very common condition, extremely common condition. Once the patient is above 45, 50 and with chronic neck pain, not able to extend his neck, or all the time there is a neck pain, that could be a cervical spondylosis. Remember the word spondylosis. And what are the main feature of this spondylosis? That there will be decreased disc space. See, this is the normal disc space. You see the disc space here. See here the normal disc space. So there is a disc cushion is there in between the vertebra, which maintains the disc space. But once that cushion hydration is gone or it is degenerated, the space will start collapsing. So you can here see decreased disc space. Once there is a decreased disc space, then what happens? The bone tries to transfer the force or the weight through forming extra bone. And that extra bone is called osteophytes. The osteophytes and decreased disc space is the hallmark of spondylosis or degenerative disc disease, cervical spondylosis or lumbar spondylosis. The same phenomenon, exactly phenomenon you are seeing here. There is a marked reduction of the disc space with sclerosis, and this is called lumbar spondylosis. Sorry. So the two common is the trauma and the degeneration. Third category is extremely common is the infection. Infection of the joint or the bone, it can happen both. So if suppose, let's talk about the joint first. This is the right hip joint space, and this is, you can see the left hip joint space. The left hip joint space, you can see maintained joint space is there. This articular margin is smooth. This femoral head is smooth also. This is a normal appearance. Where on the right side, you can see the joint space is gone. Joint space is gone. And this regular acetabular margin is also not there. And it is same on the femoral side also. I think it is little faintly seen, but if you see here, the femoral side also, there is some sclerosis is there. So essentially, the joint disease will cross both sides of the joint generally, and therefore the finding will be also on the both side. And first, it will destroy the cartilage and the supporting structure inside the joint, and that's why the joint space, which is provided by that cartilage and all, that will destroyed, and the joint space will be reduced. This is called arthritis. And this is right hip joint arthritis. The cause we can discuss whether tubercular or bacterial. Most likely it could be a tubercular. And osteopenia, if there is infection, you will see that there will be demineralization of the bone, because this is connected to the blood of the body, and because of the hyperemia, there will be bone density reduced. The focal and regional osteopenia, not the entire bone. The entire bone is good, but you can see there is a decreased density in this area compared to this area. That is called osteopenia, regional osteopenia. Many times there can be osteolysis also. I mean, the bone will be totally destroyed. It will be gone focally. So the three examples you have seen, first you have seen the trauma, another is the lumbar spondylosis, means degeneration of the spine. Same thing will happen in hands also, knee also, and shoulder also. There also will be, for I am talking about the degenerative disease. For shoulder joint also, there will be a decreased joint space and subarticular sclerosis will appear and osteophytes. Hip joint also will be same. There will be osteophytes. So degeneration everywhere, it will be same. So just this slide is kept for the hardware. I just want to make you familiar with the hardware, because once you go to the practice or in the hospital or clinic, you will see numerous kind of hardware. These are the few common. This is for PLIS, posterior intervertebral fixation device, for stabilizing the fourth and fifth listhesis. You can see this is called anterior anterolisthesis. This vertebra, fourth vertebra, is displaced anteriorly. That's why this fixation device has been put. And this is a screw used for joining the fracture lines in many places. And this is I have already shown you, this is the THR with extended stem inside the femur. And this is the wire. So different kind of hardware also you will see that you have to be aware. That is not possible to include all these things in a single class. One of the most important category and very uncommon, the tumors of the musculoskeletal systems are in a dedicated center. You may see, if you have a big hospital, a tertiary center, referral center, you can see many cases of tumor. But in general, the musculoskeletal tumors are uncommon though not rare, but they are uncommon. You won't see very occasionally in any kind of hospital setup. There are hardly 2 to 3% incident rate is there. But here, what is the hallmark of the tumor? The destruction. Commonest hallmark is the bone destruction, and there could be extra bone formation depending upon whether we are talking about the benign tumors. Benign tumors means tumor which have no malignant potential, and malignancy tumors which have destroy and it will spread to the other part of the body. Here you can see it is destroying and eating the bone of the lower part of the distal femur and forming a periosteal new bone reaction. Okay, so this specifically, if you ask, this is an osteosarcoma of the distal third of the femur, which is eating the bone as well as forming the new bone. See, all the bone tumors by default they are not like bone forming, but their cells they start producing that material which they are coming from of histologic origin. For example, a cartilaginous tumor will produce cartilage. A bone tumor, bone cells, they will produce bone like osteosarcomas. They will form bone. Those cells, abnormal cells, mitotic cells, they will form bone. That's why the matrix of that tumor will be decided by the histologic origin of the tumor. So the tumor is again a vast and very extensive region. So these are just typical some examples how they will look like. There also the periosteal reaction is there. Take a long periosteal reaction. Here also the periosteal reaction with erosion and bone destruction. So these are the tumor examples. This just the I have kept to see how the fall from height if happened. There will be vertebral collapse will be there. You can see this vertebra is of normal size, but this is collapse. This is just normal example of vertebral fracture, vertebral body fractures. This is the pelvic fracture. The pelvic area is one of the commonest area to fracture. See this, this is the fracture of inferior pubic rami. You remember? So if you know the anatomy, you can write here, okay, I have seen the fracture of inferior pubic rami. See him. Similarly, here is the superior pubic rami and the medial wall of the acetabulum. And in this area, you can see it is so extensively fractured. It has went into inside the pelvis. I am using the word protrusio acetabuli, means protrusion of femoral head inside the pelvis. See, this is the iliopectineal line. In this side, you can see it is relatively maintained, though it is fractured here. So it is entering inside the pelvis. This is a pelvic fracture. There are many types of the pelvic fracture, open book, closed book. Basically, the pelvis is a ring. So it will, most of the time, it will fracture from one side or fracture from one side and dislocate from other side, whether symphysis joint or SI joint. So this is how the pelvis usually fractures. One slide for the radiation hazard I was talking. Just I want to again remind that X-ray is a hazardous thing. Hazardous things in the sense because it has a radiation hazards. Already a calculated risk is there that if you expose a patient, they might have a disadvantage of exposure. They might have various kind of things, maybe cancer. They say one of the things. But on the level of medical imaging, because it is less than millisieverts, there is chances are very less. But you know, it is very difficult to console a pregnant patient or a pediatric population. Say for example, 5-6 years baby or 10 years child. You should be must very careful in taking the X-ray, prescribing the X-ray also. Okay. So definitely ask what is the interest. Risk benefit ratio, always discuss that if you are going to do, will the advantage will come or not. If it is not coming, if it is coming from ultrasound, do ultrasound. If it is coming from MRI, do MRI. But you have to be very careful. Briefly, I will tell what is the radiation effect. This has a two kind of effects happen: the deterministic effect and the stochastic effect. The deterministic effect is happen due to the dose dependent radiation. The more increase you dose, the more these kind of things will happen. And stochastic is due to the mutations. You hit the DNA and DNA is fragmented and changed, and then there will be a problem of cancer, leukemia, and so on and so forth. And this is again a very broad category, radiation hazard. But briefly, you should be cautious of radiation. Outside radiology department, you must have seen this signature, all the sections, especially CT. CT is also a X-ray based device. So outside CT machine also, you will see the same kind of logo. So this is from the radiation effect and radiation hazards. So almost near to my last slide. In summary, I want to revise that principle of radiography. You have remember that how it is formed, who is the discoverer, and how it is formed, from where it is formed. X-ray tube is the main component of the X-ray machine. And then most of my slides were all related to the positioning, visualization of normal anatomy, and the leveling, how the normal looks. It is very, very important how the normal looks. Then you can assess some abnormal thing. I have shown you some of the abnormal. I won't say I have discussed in detail, but I have just basic 4 category I want to make attention: the infection, trauma, tumor, and degeneration. These are the 4 categories you will come on a daily practice. Commonest I have shown you the lumbar and cervical spondylosis, the fractures, and of course infection few I have shown. And last but not the least, again, careful using the X-ray in a pregnant population and pediatric population. That is very, very important. And if you are in doubt, then before sending the patient to the X-ray department, you call the radiologist or the X-ray technician and then find out whether I should send it or not, or what should be best. If not X-ray, what will be the best to do? So my reference is most of my images were from the Clark book of radiographic positioning. That is an excellent book. We have read all. I have taken those images because it's very neat, clean, and it is showing all the things side by side, positioning, as well as the normal appearance, and as well as the leveling of the same part. Few of the images are from the radiographic journals and radio assistant online website journal, and various are from the various internet sources. And I thank you very much for all your patience listening. I hope that it will help you to start this basic understanding of the X-ray, and based upon that you can make it further and further in bits and pieces. Thank you very much. Should I stop sharing? I'll stop sharing.
Yes, sorry, then stop it. Thank you very much, sir. It was a pleasure to have you here. And on behalf of PCIP, I would like to thank you for enlightening us.
Okay. So I will just be here only, and whenever any questions are there, we can take that questions after the session as you tell us. Okay.
Yes, sir. Yeah,
Thank you.
sure.
Thank you for listening, brothers. Okay.
Thank you, sir. You're most welcome. Our second session, the topic of our second session is chest X-ray. And now I'm going to welcome our second speaker, Dr. Ashwini Kale, a physiotherapist and a Doctor of Philosophy degree holder and Associate Professor in MGS Institute of Physiotherapy, Aurangabad. Thank you for joining us, ma'am. Now I request you to kindly take over the session and enlighten us. Ma'am, you are inaudible. You are not audible. I guess the mic is off.
Am I audible now?
Yeah, you're audible now.
Thank you, Dr. Sanya, for such a warm welcome. It is so much welcome. Is it visible?
Yes, ma'am.
I'm reading. Okay. So, good morning, everyone.
Morning, ma'am.
Good morning, ma'am. I am Dr. Ashwini Kale. Today we will be discussing about chest X-rays. the basic interpretation of chest X-ray. Now, this is a very important topic and it is required for appropriate diagnosis while we are treating patients. So today we're going to cover the basic interpretation part. So the objectives of today's lecture was to understand the clinical and technical aspects of chest X-ray, to be able to interpret major findings on chest X-rays, to identify pathologies and abnormalities in the chest X-ray. So the first thing what we do is when we take an X-ray in the hand is to check for the details. Okay, check for the date of birth, age, the film date, gender, any previous X-rays we have, and for the film types. After that, when we are taking, we check for the details. The next important thing is to keep in mind that a chest X-ray is horizontally mirrored. Now, what does this mean is that the right hand side represents the body's left area and the left hand side represents the body's right area. Okay. So now when we're talking about exposure, when you look at an X-ray, we see it in black and white. As Devendra sir has told a lot of the basics, so I won't go into detail with all of that. But this is due to the different tissues which are absorbing different amount of radiations due to their density, or in other terms, what we call as their absorbing capabilities. So the denser the objects are, the less beam is striking the film and it looks more whiter. In the same way, the less dense the objects are, the more beams is striking the film and it looks more blacker. So in this way, we can see that when the beams are striking air, it looks more black or it is more radiolucent, and when it goes, and if it strikes any metal, it becomes more radio opaque or it becomes more white. Okay. In the same way, this is another pictorial diagram you can see where the air passes. You can see it's more black. When flat, it is less black. And you can see this metal, it looks bright white. So you can also notice this on the X-ray. This is how it looks on the exact X-ray. You can see this here. I'll be trying to take more of the X-ray parts. You can see more images because since this is almost like a practical session, right now in this scenario, whatever best fits, we will try to cover that all. There are three different types of chest X-ray views: the posterior anterior view, the anterior posterior view, and the lateral view. But we shall look into the details in the next part and the further part of the. So now the first part of the process, it involves assessing the quality of the X-ray. For this, we have the mnemonic RIE: rotation, inspiration, projection, and exposure. So when we talk about rotation, it first means that did the X-ray hit the patient straight or did it hit it in an angle? So for that, we will assess this by checking for the medial part of the clavicle, and we have to check whether it is equidistant from the spine or not. We can also check for the location of the clavicle, whether the clavicle is laid over the third rib or not. Here you can see the first rib. The third. Okay, so we can check for the location of the clavicle. Now, when we say the patient is rotated, how are we going to check for rotation? Another way is to see the spinous process, how closer it is to the clavicle. For example, if the spinous process is more closer to the right side, we will say that the patient has rotated towards the left side. But if the spinous process is more closer to the left side, we will say that the patient has rotated towards its own right side. Now, when I for inspiration, so how well did the patient breathe? An adequate inspiratory effort, it expands the chest and allows a greater visualization of the ribs. In that, we should be able to count at least 5 to 6 anterior ribs and 9 to 10 posterior ribs. The hard shadow should not be hidden by the diaphragm. Then about the penetration. When we're talking about the penetration, we should be able to see the ribs through the heart. We should barely be able to see the spine through the heart. And we should be able to see pulmonary vessels nearly to the edges of the lungs. Now, an over-penetrated looks somewhat like this. You can see the lung fields which are more darker than normal. And if there is some subtle pathologies, it may be obstructing the views. Okay. And an under-penetrated film, you can see the hemidiaphragms are all obscured. You will not be able to make out them. The pulmonary markings are more prominent than they actually are. Okay, so hence a well penetrated, well exposed film is very essential. Okay. Then after that, now that we have assessed the quality of the image, it is time to think about our patient. For this, we will use the mnemonic A, B, C, D, E, F, G. A is for airways, B is for bones and soft tissues, C is for the cardiac silo and mediastinum, D stands for diaphragm, E for effusion, F for fields, and G is something which I made up over the time about gears, which does mean the lines, tubes, and devices which are seen on the X-rays. So when we see for the first airway, we will first check for all the structures in the airway. Here we have to notice the trachea, the aorta, the left and right main bronchus, and the carina. So in the trachea, we have to first check whether the trachea is visible. Is it being moved or shifted from the midline? Is it deviated to any side? If it is deviated, it may stand that it is either pushed or pulled by something. For example, in a significant pneumothorax or in pleural effusion, it will exert a mass effect and it will push the trachea away from itself. However, in an event of a collapse, it may cause, due to the loss in volume, it may pull the trachea towards itself. So this we have to check. And again, we can check for the carinal angle. Here, I like to show you, this is the carinal angle. It is usually 60 to 75 degrees. You may notice that the right bronchus is more wide and more straight than the left bronchus. Now, this makes may be the reason that it is more prone towards aspiration pneumonia in the right side. Now, then check for the hilar regions. Here you can see that the left hilum is about 2.5 centimeters higher than the right. Check for the equal densities, check for the borders. Again, bilateral lymph adenopathies, they may suggest TB or sarcoidosis. However, in an event of a unilateral hilar enlargement, like here, it may suggest possible tumors. I hope you're able to see the markings which I'm making.
Yes, ma'am.
Yes, ma'am.
Okay. So you can see here in a unilateral hilar enlargement that it may be a possible tumor. Now, B stands for bones. Here the bones, as I said, we have to check for fractures, dislocations, subluxations, check for clavicle, spine, humerus, including osteoarthritic changes as well. Check for the posterior ribs, the sternum, the anterior ribs, as well as the vertebral body. So C stands for cardiac. In this, we're going to check for the heart and the mediastinum. You have to check for all the structures. In the structures of the heart, you can see the aortic knob. This is the aortic knob. You can see the main pulmonary artery. You can see the left ventricle, the right atrium, and the ascending aorta. Check for the borders. Is it well defined? Check for the border. And here, mostly you'll have to check for any increase in the heart size. So basically, we are going to check for cardiomegaly. So what is cardiomegaly? It is ideally it should be less than 50% of the thoracic window. For example, the maximum horizontal cardiac width upon the maximum horizontal thoracic width gives a cardiothoracic ratio. That should be less than 50% to call it as a normal. For example, in this X-ray, you can see. So what will you call this? What will you call this? Anyone can put in the chat box which one. This is A and this is B. So which is the normal and which is cardiomegaly? If anyone can tell me. So this is 40%. So it is normal. This is 60%, which we can call it as cardiomegaly. Okay. So here also, as I told you before, the carinal angle is normally from 60 to 75 degrees. Here you can see that it is 90 degree. Displaying of the carinal angle has occurred here. So this is suggestive of left atrial enlargement. In this X-ray, you can see abnormal findings. This is mediastinal masses here and here. Okay. So this is something you're not, you don't want. And the next is the Silhouette sign. Okay, Silhouette sign, when it happens when two various heterogeneous areas you find a shadow or a silhouette of this source here, or a shadow in this area. It refers to the less clarity of the structures at the hemidiaphragm or the heart border. This suggests adjacent soft tissue shadowing, such as a consolidated lung, and it may be suggestive of the pathology even though it is not clearly visualized. It most commonly occurs in the right middle lobe, where the right margin is obscured. Now next, going for D, for diaphragm. Here you can see the position and sharpness of the border. The difference should be less than 3 centimeters between both the sides. Okay. So on this image, you can see the diaphragm. Here I'd like to say that, see, this is the right diaphragm and this is the left diaphragm. You can see the right is a bit higher than the left. That is due to the presence of liver beneath it. You should be checking for any type of fluid which is building underneath it. Okay. This is the visualization of the diaphragm in the lateral view. Then we're going to check for the costophrenic angles. Costophrenic angles is the angle which is made between the rib, last rib, and the diaphragm. So this is a costophrenic angle. So check for it and check whether it is acute and well defined. Any obliteration or any blunting may be due to hyperinflation like emphysema. So here you can see this is the normal costophrenic angle. Here you can see blunting, okay, which is due to mostly emphysema. The next thing is to check for a gastric bubble at the left, under the left diaphragm. So this is the gastric air bubble. After that, we are going to check for the lungs, or in other ways in our mnemonic, we said about E and F. So E is for effusion and F is for lung fields. So in this, we are going to check for the pleura. We are going to check for any pleural thickening, calcification, plaques, pneumothorax, or any effusion. Okay. So here we can see an example of pleural plaques. Here you can see this is pleural plaque over the lung field. Okay. Here also you can see some pleural plaques. Okay. In this also we have them present, but along with that you can see pleural thickening in this X-ray as well. Now remember that usually when we normally study, we divide the lungs anatomically into lobes by the horizontal and oblique fissures. So we divide the lung into 3 lobes and left lung into 2 lobes. Okay, but on a chest X-ray, when we are going to, it helps us to interpret it by dividing them into zones. So we divide them into upper, middle, and lower zones. It helps us to easily report where the opacity of the lung is present or where the other abnormality is present. For example, this is the right upper zone, the right middle zone, the right lower zone. This is the left upper zone, left middle zone, and the left lower zone. So for example, here, can anyone see where the opacity is? Okay, you can see it here. So according to our zonal areas here, you can check that it comes in the lower zone. So here we can report that the radiographic density, okay, or the right lower zone is having consolidation or any abnormality. Then check for apices. You can check for any Pancoast tumors in the apices. Now moving to the last part of our mnemonic, which is G4 gears. Here I like to show you the different types of lines and tubes which are present, so that when you're reading a chest X-ray, you should be aware of the linings. Okay, so this is a central line. You can see central line here. The next is the endotracheal tube. Okay, so it is very essential or very important for us to check on an X-ray after inserting of the endotracheal tube, because any advancement too far will lead to complications. For example, this is the right position. Okay, it should be about 3 centimeters above the carinal angle. Okay? If it advances too far, for example, in this area, as the tip is in the main right main bronchus, it may lead to collapse in those areas, which we don't want. Now the nasogastric tube, the proper placement of a nasogastric tube should be confirmed. For example, it should descend centrally, then it should cross the diaphragm, and afterwards, once below the diaphragm, it should initially deviate towards the left side. Okay, so this is the appropriate position. Whereas here, what do you see here? What do you see here? You can see that it advances into the right leg. Very rare, it's not too common, but still it is necessary to check all of these things on the X-ray. So this is a chest tube and used for draining. Then these are the telemetry electrodes and the wires. Okay, do not mistake these for any findings on the X-ray. Okay? So this is why it is necessary for you to know how they look or how they appear on a chest X-ray. Okay? So now we'll review the anatomical structures once again. So here is the trachea. Okay, you can see the trachea here. You can see the heart. Okay, then the clavicles. You can see the gastric air bubble. Okay, the right hemidiaphragm and the left hemidiaphragm. You can see the pleura. Okay, then you can see the fissures. You can divide them. You can see the scapulas. Scapulas are more visible on the AP view. So now, suggestive to this, you can see the review areas on a radiographic aspect. So we'll check the apices for pneumothorax, tumor, and cervical ribs here. We'll check for the AP window here. Now this is very light, but if you look very closely, you can see the carinal angle here. Okay, this is there. Then you can assess the heart borders. Okay, the density of the heart, same on both the sides. You can check for the hemidiaphragms. Okay, you can check for gas under the diaphragms. Check for all the soft tissues as well. Check for outline of all the bones for any osteoporotic changes. Okay, so now let's review. How am I supposed to see the chat box here? Sorry. How will I be able to see the chat box while I'm sharing the slides? Will anyone help me for that? How am I supposed to see the chat box? Okay. So here I've brought the chat box. Now I want you all to actively participate. Okay, in the chat box. So now let's review an X-ray. So this is an X-ray. Here you will not be able to see the details of the X-ray because it is just for your practice. So we're going to start with right. So we're going to check for the rotations. So are the clavicles equidistant? Okay, yes, they are.
Yes.
Yes. I request you all to don't unmute yourselves. Just type everything in the chat box. So we are going to be having a this interactive session as also in the next few slides. So I want you all actively participating in the chat box. Okay. So first we saw the rotation. It is equidistant. Then we saw for inspiration. Yes, we can count up to 10 posterior ribs. Even if you go for the anterior ribs, you can see 1, 2, 3, 4, 5, and 6. So 5 to 6 anterior ribs or 9 to 10 posterior ribs. Then projection. You could see here that the spine is not seen clearly, so it is well projected. Then airway, A for airways, you can see the trachea. Okay, it is not deviated, it is not pushed or pulled to any side. Okay, you can see the pleural outlines is well defined. The heart size seems well defined and no obvious cardiomegaly as such. You can see the hemidiaphragms. Okay, well defined hemidiaphragms. The costophrenic angles are acute and well defined. Here you can see a gastric air bubble beneath the left diaphragm. Okay, so has everyone understood this?
Yes, ma'am.
Okay, so now we're going to go for the difference between a PA versus an AP film. The reason why I kept this not in the starting is because now you know the structures and the normal structures which are included in the chest X-ray. So we're going to check out this now. So can anyone tell me, everyone type in the chat box, what is the difference? What do you feel is the difference between? This is the PA view and this is the AP view. So any differences? I'll just check. What differences do you see? Anyone? Okay. Yes, very good. Scapula and the vertebra visions. Very good. Clavicle prominent in PA view. Very nice. Spine. Okay, very nice. Okay. So again, one more difference you can see is the heart is seen enlarged here. In an AP view, we can see the heart more enlarged. Yes, cardiomegaly. So the heart is seen enlarged here more than the PA view. Exposure. Very nice. So why is this happening? So first of all, I like to show you this, that when we are talking about the PA view, you can see the heart structures here and the distance between the screen is quite less. So when X-rays are moving parallelly and it falls on it, it gives the exact same size, accurate size of the structures. Whereas in the AP view, here you can see that the structures, okay, they are at a more larger distance, which causes the rays or the parallel rays to reach a bit in an exaggerated or an outward direction in this way. So it gives it as an exaggerated size. So that's why we can see the heart structures or all the other structures in a more, we can see it as a cardiomegaly. It is in the same way that when you stand exactly when the sun is on your head, you can see that your shadow is on the exact same size. But when the sun sets down behind your back, you can see that your shadow has become more larger, and in the same way, you can see all these structures. Now, lateral view. What are the structures which we can see in the lateral view? Trachea, aortic arches, the pulmonary artery, the right ventricles, and the left ventricle. When is lateral view? Usually lateral views are required when we want to review or reassess any X-rays. For example, this is an X-ray of an army man. You can see that there's some shrapnel injury. You can see one shrapnel here. You can see one shrapnel here. So after looking at this, we are unable to locate it exactly, the location of the shrapnel, because we would like to remove it surgically. So for that, we'll take a lateral view. In the lateral view, you can see the shrapnel is well settled in the posterior lower lobe. So such views are very essential when we want to review. Okay. So now I'd like everyone to concentrate and we'll see some cases. Okay, you are open to type in the chat box if you find any findings. So can anyone tell me this? Can you review this? Okay, in the starting, I'll start a bit. Here, see, here we can see the costophrenic angle is sharp here, but you cannot find the costophrenic angle here. This is the meniscal side, pleural effusion. Yes, left lower lobe is collapsed. Very good. This is a classic meniscus sign of a pleural effusion. Very good. So now the next one. Can anyone tell me this? Can you see some structures here? So these are calcified pleural plaques. Very good, Bhumika. Okay. Yes. Okay. So now this. Okay. You can see consolidation. This area you can see consolidation, and whereas the opposite side is clear. See, this is why we should check for the bones as well. You can clearly see it. Okay. Now the next slide. Can anyone tell me? This is a normal chest X-ray. Yes, you can see. Only the thing is that the spine is a bit rotated, but other than that, there is no abnormalities along with it. You can just see a bit of rotation. It's not equidistant from here, but other than that, it is all normal. You can see very well defined osteophrenic angles. There is the cardiac width above the thoracic width is normal. There is no fissures. You can see the stomach bubbles. Now this. Can you tell anything? Anyone? You've seen something here? You can see consolidation there, and even more you can see the diaphragm is flattened. Yes, CP is blunt. Very good. Yes. So now this, yes, I want you all to pay attention to this one. So these are the lines. You can see the internal jugular catheter here. Okay. Then one here. The position right. Yes, is the position of the nasogastric tube right? No, yes. So after seeing this X-ray, you should come to the conclusion that you should remove the nasogastric tube. Okay. So here also we can see the ET tube is also a bit, we can just move it up a bit, but still it is normal. But the nasogastric tube should be removed. It is wrong. Anyone can tell me this, okay? Who can see any abnormalities here? Yes, very good. Rib fracture. Very good. Very good. Okay. And then you can see here also ataraxia. Okay. So now we'll have a small quiz. We'll see who can answer fast. Okay. So everyone ready? I'm going to start my first slide. Okay. So keep in mind your RIPE and ABCDEFGs. So if you follow that rule, you'll be able to find it very well. Can anyone tell me what this is? Very good. Very nice. Okay. So yes, this is a case of extracardia. Very nice. Now the next slide. Now this is quite easy. You will be able to see. But can you see here? Yes, consolidation. Very good. So it is segmental pneumonia. Very nice. Very good. You can see there's compensatory hyperinflation in the left side. You can also see the crowding of ribs on the consolidated area. Okay. So now the next slide. Can anyone tell me this? I'll give a hint. Do you know what this is called? It's called a honeycomb lung. Yes, bronchiectasis. Very good. So there are scattered opacities in the right lung. It is also, we can see it in bronchiectasis or in fibrosis. Okay. This we have a classical sign here. Does anyone know the sign of this X-ray? We call it as a butterfly. Okay, it's a butterfly shadow. We usually see this in pulmonary edema or in early ARDS. Okay. Now this one. Can anyone tell me what this is? Okay. Yes, very good. There's air because it is hyperinflated. You can see bilateral hyperinflated air. You can see a tubular heart here. Okay. And okay. So now the last one. Sorry, one more is there. Okay, so this one. Again, I had showed you a previous one here. I'm giving you hints. No, it's not a plate. It's a right upper lobe collapse. Okay. The last one. Can anyone tell me this? Very common. No, it's not a consolidation. You can see hyperlucency in the right side. Very good, Dr. Balaji. Okay. So this is seen, we can see the shift of mediastinum along with the cardiac shadow to the opposite side. This usually happens in tension pneumothorax. Yes. So this is the child's pediatric X-ray. Okay. You can see the hands holding their arms, you keep them positioned. Okay. So this was the last slide. I hope you all understood everything. We went through the basics of the X-rays. We've seen the mnemonics, we've seen RIPE, we've seen A, B, C, D, E, F, G. And I really think that you all will be able to now at least resolve everything will be very easy.
Thank you, ma'am. It was a pleasure to have you here.
So,
Ma'am, I would like to ask some questions.
okay, so we'd like to have sir along with us. I think he's also waiting.
Yes, ma'am.
Sir is joining in a while. He's joining.
Okay.
Okay.
I'll stop sharing.
Sir has joined. Hanji ma'am, please.
So, should I start?
Anya, please ask questions.
Yes, ma'am.
I'll just.
Sir, so the very first question was for you. How will we define flat foot without X-ray? Is there any measurement of bone alignment to describe flat foot on X-ray? Such we have Cobb's angle for scoliosis. Is there any such angle or measure for flat foot?
Okay, that's really a very good question. In the flat foot without X-ray, probably I'm from radiology. I may not be the correct person to say how without radio, how without like X-ray you can do. I can tell you with X-ray a few. The flat foot, basically we divide into the congenital part and the acquired part. Acquired means I told you due to some trauma or due to neuropathic joints, where the supporting structure between the joint will be the affected one. I'll just can I go to my Can I go to my slide? Can I go to my slide to show? No?
Yes, you can.
Share screen, I will go. I'll go share screen and just open the footage. I want to open the footage. Can you see the? Can you see
Sir,
the
it's
last
yes,
screen?
sir.
Okay. I just want to go to the foot one. So I was talking that there are angles are there to measure the flat foot. There are 3 angles. So if you are more interested, then you can go to the radiographic journal and if you type flat foot deformity, you will come to an article which gives you in a tabulative format the angles. So really in routine practice, I do not use it because my orthopedic colleagues come with the examination and then he see the X-ray. And if he is satisfied that there is something wrong with this angle, then he labeled it as a flat foot, unless it is not very visible easily on the lateral. This is the X-ray I'm talking about. This is the lateral foot X-ray. You see the longitudinal arch. Longitudinal arch is the flat foot. So there are 3 angles. First angle, the talus and the long axis of the first metatarsal bone. They should be always in parallel. Can be a little bit up and down, 4 degree angle, but most of the time they will be parallel, less than 4 degrees, like this. So if it is maintained, then there is no flat foot. The assessment of medial longitudinal arch because the first metatarsal is arranged on the medial side. Second angle is relation with the horizontal as well as this base of the fifth metatarsal bone, which is on the lateral side. So it gives you the idea of the lateral side of the longitudinal arch. If this is coming down, this is coming down, and the angle between this line, this dorsal aspect of the calcaneum, and this line, this angle is decreasing and decreasing, then it means there is something wrong with the lateral longitudinal arch. And here, if this angle between talus and first metatarsal bone, if it is increasing like this, the talus is here only, but this first metatarsal bone is dipping, and mainly the flat foot happens due to the laxity or the abnormality of the mid tarsal joint. We call it as a distant joints also. If there is abnormality in this area, there will be sagging. So the angle will increase. The talus will be like this, the lateral axis, but the first metatarsal bone will keep dipping and dipping. The angle from 4 degree or 0 degree it will in last increase. So that is the indication of the flat foot on X-ray and lateral view. Third measurement is also the same. Normally we take this X-ray on a weight-bearing surface. We ask the patient to stand on the X-ray machine, and natural foot is weight bearing kind of thing, body weight especially, and it will get flattened. And this angle that I'm talking about is getting disturbed. The angle between the talus, long axis of talus, and the long axis of the first metatarsal is increasing and increasing. Then we call it flat foot. Severe is more than, I think it is more than 20 or 30 degree. And same stand for this calcaneum fifth metatarsal angle also. If you think more than 20 it is written. If somebody wants a reference, you can go to the radiographic journal. There is a big article is given how. So there is a clinical integration also as well as radiographic integration is there. But in nutshell, there are measurement. There are 3 angles measurements are there. First I told between the talus and the long axis of the metatarsal bone. The second between the horizontal surface of the foot and the weight bearing. All these are in weight bearing. Angles are in weight bearing technique. And base of the calcaneum. Third angle is base of the plantar aspect of the calcaneum and the most part of the base of the metatarsal. These are the 3 angles which is very commonly used. The first angle I think called as a Mary angle or Mary angle. So this is the Yes, I think hope this answer the question he has asked. But without X-ray, I don't know really how to do it. The clinician can tell. The orthopedic colleague, if you ask, they can able to say. Really, I cannot say without X-ray.
Okay, sir. Thank you, sir. Next out is how can we identify low calcium levels in X-ray?
Okay, low calcium level. I understand the meaning of blood. He wants to say blood. I assume that suppose he is telling or she is telling blood calcium. If means he wants to say that there is a calcium is low in the blood, then osteopenia probably is talking about osteoporosis. Osteopenia or osteoporosis. I have shown one image where the osteopenia was visible on the X-ray, but it only happens when it reaches beyond certain level. See, there is no direct correlation between the blood calcium and the low density of the bone. The low density of the bone is due to the entirely local process, or it could be a part of generalized process also. Local process means infection or maybe a osteoporosis or osteopenia of the entire bone will be there. The bone will be a low density compared to the normal. And whenever he's talking about calcium, then we have a different discussion. Typically, density will be reduced, but in advanced stage, not in the early stage. You will okay? Like something like rickets patient, chronic kidney disease patient, they show the low density actually. Later they can show the high density. Also, this hyperparathyroidism. The hyperparathyroidism patient also, they also show very osteopenic kind of feeling because there is a resorption at all levels, cortical resorption, periosteal resorption, even the medullary bone also gets fading away because of the high level of calcium in the bone. The density of the bone comes down. Similarly, if there is a low calcium, it has to be very specific what you mean by low calcium. Because low calcium happens in many conditions and it doesn't directly correlate on the X-ray density. Okay.
Yes, sir. So the next question is how can we differentiate between degenerative changes and calcification?
Okay. Degenerative changes. Just want to go to the lumbar spine X-ray. So degenerative and calcium. See there is a bony projections is there, and there are some calcification also is there. These bony projection is called osteophytes. They are usually in continuity with the parent bone. They are not separate from the bone. That's why they are called osteophytes. And this is the signature of a degeneration. This bone, extra bone, which is connected to the parent bone, is called osteophyte. They are called degenerative cervical spondylosis. So that method, lumbar spondylosis also, here is also a bony projection is there. And calcium, suppose if it is in this location or somewhere else, or if it is here also, there is a different explanation. This is separate from cervical bodies, but these are called annular calcification. Annular. The nuclear, the disc, cervical disc has two parts. One is nuclear pulposus in the center, and periphery there will be annulus. So annular get calcified in a degenerative process, but it will be limited to a disc space only, or it could be a detached osteophyte also. Initially, it might have been attached to this vertebra, but now it has been a little bit detached. This can be a detached osteophyte. So, in nutshell, the osteophytes are attached to the bone. This indicates degeneration, and a calcium which is away from the bone somewhere else, then it is called a I hope that this has explained the question.
Yes, sir. So
So
we are done.
we are done.
Yeah, we are done with the question.
Okay, then I'll stop sharing.
Thank you so much, sir and ma'am. Now I would like to invite our officiating in charge, Dr. Nidhi Kalra ma'am, to deliver vote of thanks.
Thank you, Dr. Ravi, for this beautiful session. On behalf of BCIP, I would like to extend my gratitude towards Dr. Devendra and Ashwini ma'am. Thank you so much, sir, and thank you so much, ma'am, for sparing your very precious time and giving us this very important and utmost required information and knowledge. Thank you so much, sir. It was great having you here. And Ashwini ma'am, thank you again. And I hope we are in contact for more such future events. I hope to have more association with you, ma'am and sir. Thank you so much, sir. Thank you so much, ma'am.
Thank
It
you,
was
ma'am.
great to have you here. Thank you, sir.
Thank you. Same here. Same.
Thank you so much.
Hello, Ashwini ma'am.
Yes.
I have certain queries to be clarified. You can I proceed, ma'am?
Okay, or else if you want, shall I give my, is this over or shall I give my mail ID?
Ma'am, it's okay if she wants to ask or you want to give email ID, whatever you want to prefer.
Okay, as you say, ma'am.
Yes, ma'am. In case of pneumothorax, if the external wound are opening caused by any stab injury and gunshot injury is too large or greater than the opening of the trachea.
Can you talk slowly? Or else
Yes,
can you
ma'am.
type your query? I can't understand.
Let me say it slowly, ma'am. In case of pneumothorax, if the external wound or injury caused by gunshot injury or stab injury is too large than the opening of the trachea, it may result in lung collapse or even in death, ma'am.
Yes. Yes.
Yes, ma'am. That is my question.
That is your question. Okay. Yes. That depends upon the extent of the stab and the structures which are going to be affected due to the stab. It may cause incident, it may cause collapse, and then the collapse may lead further if it's not treated.
Yes, ma'am. And then if a baby is swallowing a coin, it is more frequently going and obstructing the right bronchus more common than the left bronchus. This is why, ma'am. And in this,
in my slide, I'll share my slide once again. I'll show you.
I'll stop sharing, ma'am.
Yes, sir. Yes, sir. I'll share it from my slide. Remember, I had a. Yeah. Okay. So as I said at that time also. Yeah. Okay. So here you can see the trachea. Okay. So your question is why it is more into the red. If you can see this right bronchi is more wide and more straight than the left bronchi. So what happens is when we swallow something, it is more likely to go here because it is more wide and more straight. Once it's in an angle, it won't go inside. So that is why I told during the presentation also it is more likely to cause aspiration on that side. I hope you understood.
Yes, ma'am. In village side for this, they would hang the baby upside down and beat on the back of the baby, ma'am. Is this right or it is considered as myth or false procedure, ma'am?
We won't consider upside down. We will usually just bend them downwards and give a push. Upside down, I haven't heard about that myth or that procedure.
Yes, ma'am. In COVID patient also, they are saying the prone position is more advisable for good oxygenation, ma'am. But the weight of the body won't compress the heart, ma'am, in this position.
No, I don't think so. Weight of the body won't be an issue.
Yes, ma'am. Thank you so much, ma'am, for clarifying my doubt.
Thank you, ma'am. Thank you for extending your talk. Thank you, sir.
Okay, thank you, ma'am. Pleasure here, same pleasure. Okay.
Thank you.
वाला मैं छोड़ो अरे नहीं वो ना कुको बैठ के घूमती होगी ना इधर उधर तो उससे पढ़ता हो अब पढ़ ले अब हो जाते डिस्कस करना है तो बोल दे, मैं पूरा हफ्ता रुक जाऊंगा। हाँ नहीं जाऊंगा पोस्टिंग, इग्नोर क्या होगा, मेरा कौन सा जन्नत रुक जाएगा इतनी पोस्टिंग छोड़ के। हाँ रुक जाऊंगा, 24 को है सकते, बस 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 29 को पेपर